Okay, so we're going to move into sonography of the finger. And, it's interesting, the speed with which I talk, it keeps coming up, and I'll just tell you, I don't notice it. I've tried going slower, it never works. Anyway, and the benefit is I can cram more into the same 20-minute block. So going slow is not going to happen here because we've got a lot to cover. But at the outset, one of the things I would say is that I'm continually surprised by what you can do with ultrasound. Again, I would just encourage you not to get involved in the silo mentality that there's certain categories of things you're going to use for one modality or another. It is still not uncommon. It's both a blessing and a curse to have a technologist that does a lot of these things for me, that does nothing but musculoskeletal ultrasound. She often brings me cases, and I kind of look at her, I'm like, you got to be kidding me. And then, inevitably I go up and I watch, and, there it is. And the number of times you've had MR correlation that confirms, or surgical correlation that confirms is high. So I think certainly it's not an answer for everything, but it's quite a powerful modality, and that includes imaging of the finger. So our outline here will include a few brief overview points, then we'll spend our time looking at technique with emphasis on the normal anatomy. We'll go over these categories and more throughout the course, and also relevant pathology. So much the same as with shoulder ultrasound, one question asked is really why bother with this business? We have MR, and I think the answers to this will be similar to what we observed with shoulder ultrasound. Modern transducers are able to achieve a higher space resolution than that with MRI. And certainly when it comes to tendons, our sensitivity and specificity for disease is at least equal to MRI. Certainly also the fingers are accessible structures to us, even in our thickest of patients. Typically we can get by with using those high-frequency transducers and see structures in question. It also allows us a dynamic evaluation that clearly is just not achievable currently, at least on a routine basis with MR. It allows for assessment of pathologic motion as well as retraction. Now, certainly, you can see retraction of torn tendon stumps on MR, but it's not uncommon, still in my practice, that the stump is retracted beyond your field of view. It's something that's common knowledge for all of us, but to achieve high-resolution imaging on MR, often you can't image the whole hand, wrist, and fingers all at the same time. So it is not unheard of for your retracted tendon to be beyond your field of view, and unless your technologist spontaneously images more proximally, you're going to miss it. On ultrasound, that's never going to be the case because you're going to go fishing until you find the tendon. It also allows an instant comparison to a normal control. Certainly with MR, you've got ipsilateral fingers within your field of view. With ultrasound, you can even one up that and go to the contralateral normal finger, presuming it's normal for evaluation. We didn't touch on this with shoulder, but and again, I know that you guys are relatively sheltered from billing within the military, but it does tend to influence how you perform the exam. And in 2011, there's been a revision of CPT codes which affects how we perform our exams. There typically now is two categories, either focused or complete. A focused exam in the case of a hand would be to evaluate a problem area only. Okay, that is, there is a mass. Let's say that the surgeon wants to know is there a ganglion cyst, and you go in and evaluate the cyst alone. All right, that is a slightly reduced charge, but it's a focused exam. Certainly is pretty quick to perform, however. The complete exam would include examination of an entire flexor or extensor surface. It doesn't require both. Essentially, if there's a finger that's problematic, if you image the entire flexor surface of that finger from the palm to the distal phalanx, that would entail a complete exam. So the technique, I think, here is largely self-explanatory. You want to use a high-frequency or linear array transducer, capacious volumes of gel necessary to avoid air gaps. And, when I got here, I thought something happened that they changed gel because it was like so runny. It was a little more viscous than water. And of course, I get into this next practice, and the gel's back to normal again. It's got some viscosity. I mean, I think with the gel here, if it's that runny, you're going to have problems. All right. And if you notice that the surgical gel, if you really need to, the ones that comes in the sterile packets, that's a little bit more viscous, and you can always get by with using that if you need to. You can use a standoff pad. I'll tell you, my technologist, and in my experience, lots of gel is a little bit better than the standoff pad, but to each their own. Certainly, our imaging is going to be performed relative to the finger, both in short and long axis. So we're going to spend some time looking at some relevant anatomy at the flexor surface, and then we'll spend most of the time looking at the sonographic appearance of these structures. So here's a line art image from a Netter diagram that I've stolen, but it emphasizes the two important structures at the flexor surface. Shown in yellow here is the flexor digitorum profundus tendon, which, although it lies deep to the FDS, or flexor digitorum superficialis, it has a more distal insertion. Okay, so that leads to interesting anatomy at the level of the proximal interphalangeal joint. Whereas shown here, hopefully reasonably well, is a split in the FDS as it inserts on the proximal shaft of the middle phalanx, allowing the FDP to pass through. Certainly something else you want to pay attention to is the pulley system of the fingers. Okay, there are two components to the pulley system. One of these is the annular pulley system. They're shown in red and so named because they're roughly annular in their morphology. Not shown in this picture is the A0 pulley, which is a pulley that's located at the level of the metacarpal shaft, but otherwise they are named in order from 1 through 5, proximal to distal. And again, we're going to examine these more in detail soon. Certainly we've got intervening between the annular pulleys, cruciform pulleys, again named because of their morphology. There are 4 of these, C0 through C3. A recent article was published as of 2005 asked the question, how reliably are these pulleys seen on routine sonography? And their conclusions indicated that you should see A1 through A4 reliably on any finger examination. A5 was somewhat variable, and actually in their data it was not commonly seen. And C1 seen roughly half the time. And my technologist, who I think she's good to her credit, she's a little overconfident at times, but she would say that she can routinely see all the annular pulleys and most of the cruciform pulleys. Frankly, images that she shows me of cruciform pulleys I have a hard time believing, but she says she can. Certainly another important piece of anatomy we want to pay attention to is the volar plate. This is analogous to the plantar plate in the foot. Essentially, this is capsular thickening. On the sagittal image above, you see that there's often a thin membranous component that has a name that I can't pronounce. But nonetheless, it originates at the distal shaft of the bone at the proximal joint. It becomes focally thick at the volar aspect of the joint and attaches to the volar end plate of the distal osseous structure. These are present at all 3 joints of the fingers. Okay, they're more pronounced at the metacarpophalangeal joint. The short axis view shows in red the volar plate proper. I've included this image largely to emphasize that there's much the same as with ligaments in any joint, be it glenohumeral joints or even collateral ligaments in the knee. There's extensive fibrous continuity. In the case of the volar plate, you'll see that it's contiguous with joint capsule, collateral ligaments, ultimately even the pulley system. And perhaps the reason that that's important is it's very difficult to tear one thing in isolation. Often there's adjacent injuries. At the MCP joint, the volar plate is contiguous with components of the extensor hood as well. So let's start looking at the sonographic evaluation of that flexor surface. So we're going to begin at the level of the metacarpal shaft, roughly where the red triangle is located. 2 things that we're going to see at this level that we didn't go into in detail before, but I'll just point out here, include lumbrical and interossei musculature. Okay, so the lumbricals are a little bit more volar in their orientation. We'll come back to these when we discuss the extensor hood. But here's a representative short axis sonographic image at that level, and you can see the shaft of the metacarpal, which shadows here in red those fibers of the lumbricals. Again, remember that we're at the flexor surface, so things that are closest to the probe are more volar. And then we see some of the distal muscular tissue of the interossei. Certainly, you can see the flexor digitorum superficialis and profundus tendons quite well, and as noted by the technologist in calipers, you can see the annular pulley. We're going to come back into the morphology of the annular pulley here in a minute. Okay, but anyway, that's the or the A0 pulley. Again, at the level of the metacarpal shaft. So we're going to move distally from the shaft to the level of the metacarpophalangeal joint. And on long axis imaging, we should see something that looks roughly like this, where you can see flexor digitorum superficialis and profundus tendons in red and yellow, respectively. And then if you look closely, you can see, as denoted by the technologist, and again, I'll take the red off just to show you, easily identifiable as an asymmetric thickened band of hypoechoic tissue representing the A1 pulley. And we'll come back and look at this on short axis in a moment. In yellow, you see the thickened capsular tissue representing the volar plate, and indeed, we can even see some articular cartilage at the volar surface of the metacarpal head. In short axis, we can again see flexor digitorum superficialis and profundus tendons. And I'll tell you that on static grayscale imaging, it's often difficult to identify the 2 tendons in short axis. Real time, it becomes somewhat easier, particularly with dynamic motion of the finger. Here, deep to that hypoechoic tissue is the volar plate. And then in red, you see components of the annular pulley. And again, that's right, I forgot I mentioned this. So here, depending on the patient, you often can see some distal muscular tissue of the lumbricals, and certainly you've got neurovascular structures. You have to take my word for it that these are muscular tissue of lumbricals. So what I'm pointing to here in the red arrows is just to emphasize a point. The annular pulleys will always look thicker lateral to the flexor tendons, and that is in large part due to the wall-echo-shadow complex that you might be familiar with from imaging of the gallbladder. And it also emphasizes the point that you don't want to assess thickness of a structure where it is oriented parallel to your ultrasound beam. Largely because of artifacts like this, you'll overestimate its size, and where you want to estimate its thickness is when you're perpendicular to the beam. How thick is a normal annular pulley? Roughly on the order of 1/3 of a millimeter, plus or minus around 0.5. according to a recent article that examined this. By the time you get to a millimeter or thick, it's probably too thick. Again, this is just emphasizing that depending on your patient, those lumbrical muscles might be, and even interossea might be a little bit more pronounced. So here we are at the level of the A1 pulley, but you still see some predominant myotendinous tissue of those lumbricals, and then perhaps there are some interossei. So we're going to save most pathology till the end. I just want to emphasize a point here. The image to your left demonstrates a normal A1 pulley, and that's compared to an image that I've lifted from the web, which shows a grossly thickened annular pulley. Clearly, it's easy to identify the thickness and clarify that it is pathologic here. You would be hard-pressed to denote any difference in the thickness of the annular pulley at the lateral margin of the tendon between the normal and the abnormal. And again, it just emphasizes don't measure the annular pulley laterally. Measure its thickness here. And obviously, thickness in isolation is rarely a manifestation of disease. You typically will see appropriate clinical symptoms for 1 and 2 that the tendons will be abnormal, usually tendinotic. So let's move our attention distally now to the level of the proximal phalanx. Our long axis imaging should identify both the FDS and FDP tendons as shown here. And similar to our long axis image at the level of the MCP joint, if you look closely, the red arrows denote some asymmetric hypoechoic tissue representing the A2 pulley at this level. Turning our probe 90 degrees to get a short axis image, we'll show the flexor digitorum superficialis tendon to be somewhat more crescentic in its morphology. Again, remember, it is getting ready to split at the level of the PIP joint. Okay, so its morphology will often look a little bit more concave at its inferior border, or its deep border here. There's the FDP tendon, and again, the calipers placed by the technologist show you the A2 pulley here. So we're going to continue to march distally in the finger. Here's a sagittal or a long axis image at the level of the PIP joint. Again, we see the flexor tendons in this location. Nicely shown, here's the entire extent of the volar plate, again emphasizing that small, thin, ligamentous-like communication with the distal shaft of the proximal phalanx in this case. Now, if we move our probe just slightly distal to the level of that joint, this image, we weren't intending to see this, but that hypoechoic band denoted by the arrows are some of those insertional fibers of the flexor digitorum superficialis tendon, which I tend to find much more easily on long axis rather than short axis imaging. They're hard to see on short axis. And then here is your flexor digitorum profundus tendon, and then again, noted by the technologist, by the 2 calipers there, is the A4 pulley. So that's right here. Just to emphasize, before we go into short axis view, is the anatomy at the level of the PIP joint of the flexor digitorum superficialis tendon. This is the image that I showed you on the previous slide. If attention is given to this region, you can commonly see a well-defined flexor digitorum superficialis tendon. Indeed, it attaches onto a small tubercle at the proximal shaft of the middle phalanx as shown here. And again, I tend to find these problematic to see on short axis imaging, but on long axis they should be reliably seen. So this is a short axis image at the level of the PIP joint. This emphasizes a point that just be aware at the level of your joint that you've got a thick volar plate. So not all of the tissue that we're looking at over the bone here is going to be flexor tendon. We'll come back to that in a minute. But anyway, here shown by the technologist and color-coded by me is the A3 pulley. And then deep to that you see 2 paired, relatively small flexor digitorum superficialis bundles. And in the middle of that is the FDP. Okay, the tissue deep to that is the volar plate. Okay, which is quite asymmetric in its thickness compared to the thickness of the tendons. But just bear in mind, it will be present on those short axis views. Now, this is an analogous image to the level of the middle phalangeal shaft, where we've slid just distally, still in short axis. Here you see the FDP tendon, and then again the red arrows point to, in this case, the A4 pulley. And I realize I'm showing you representative images, but take my word, if you're looking for the pulleys, you typically can see them if they're a component of your search pattern. So moving distally now to the level of the distal interphalangeal joint, the first image above is a representative long axis view where you can see in entirety the flexor digitorum profundus tendon to its insertion on a corresponding tubercle at the volar surface of the distal phalanx. In keeping with other joints we've seen thus far, you can see volar plate tissue here as well. In short axis, there is the A5 pulley. This one can be tricky, but there it is. You can also see some of the flexor digitorum profundus tendon tissue, and then again, thickened capsular tissue representing the volar plate just deep to it. All right, so with that, let's turn our attention to the extensor surface. Extensor anatomy is equally intricate to that seen at the flexor surface. We begin at the level of the metacarpal shaft with a singular extensor tendon. It receives a number of fibrous contributions at the level of the MCP joint, in large part due to the extensor hood, which we'll mention here in a moment. But ultimately, that extensor tendon will extend distally as a central slip or band. which will insert on the dorsal aspect of the middle phalanx, and then paired lateral bands, which will insert on the dorsal aspect of the distal phalanx. Now, in keeping with comments made previously on the extensor hood, it contributes to the extensor mechanism. In large part, it receives tendinous contributions from interossei and lumbrical musculature. All right, we'll see this on short axis views particularly well. So we're going to begin our assessment at the level of the metacarpal shaft, and at this level, anatomy is not particularly exciting, and this is not the world's best image, so I apologize for that, but the blue line there shows the metacarpal shaft. Here are some of the distal muscular fibers of the interossei. Perhaps that's a lumbrical, and there, again, take my word for it in this image, but that's your extensor tendon. As we move distally to the level of the extensor hood, we get into some more exciting anatomy, potentially, and I, again, apologize. My technologist, she gets very excited and is trying to label lots of little things. But the take-home message here is that if you look carefully, you can see some more defined hypoechoic tissue here, which has that kind of tendon architecture. It's fibrillar in nature. That's your extensor tendon. And in blue over the top of it with lots of calipers is the extensor hood at that level. And then certainly you can see a little bit of dorsal joint capsule as well as some articular cartilage overlying the metacarpal head. In long axis, you'll recognize that this image looks quite similar to that we saw at the volar surface. There is your flexor extensor tendon, and overlying it, the hypoechoic band of tissue is the extensor hood. So this small band of hypoechoic tissue is just subcutaneous fat. And here you can see some gel that is just deep to the ultrasound probe. And again, I think real time, it's much easier to see these things, particularly with dynamic manipulation of the finger. So we get to the cadaver lab, this will become more apparent. Recognize we see some dorsal joint capsule that is quite similar in its appearance to what we saw at the volar surface representing the volar plate. You'll also see it particularly well at the MCP joint. So as we move our probe distally to the level of the proximal phalanx, again, there's a brief pause in excitable anatomy here. There's just a singular extensor tendon with contributions from the extensor hood. We don't see those lateral bands quite well on this image. As we move just distally, though, some of that anatomy becomes more apparent. So here, shown in calipers by my technologist and in red by me, you can see the central slip at the level of the PIP joint, and then the paired lateral bands. And again, I think real time, these are a little bit easier to see. Ultrasound's always tricky when somebody stacks a bunch of static grayscale images and colors them for you, but real time, I'm always impressed about how easy these things are to visualize. So on long axis views of the proximal interphalangeal joint, if you look carefully, you can see the central slip as it attaches onto a small tubercle, again at the dorsal aspect of the middle phalanx. And again, if you find the tubercle, often you'll find the tendon right next door. If we move just off midline, and I think this becomes one of the more challenging components of the exam, you can find those paired lateral bands. You know you're lateral in this case because you can see some of the superior fibers of the collateral ligament at the PIP joint shown in yellow. And you have to be careful because you can see some of your digital nerves that are also in this location. There's an example of a lateral band. So moving to the distal interphalangeal joint, on your long axis view, the red arrow points to the joint line with distal and middle phalanges labeled for you, and here you can see the relatively thin and delicate lateral bands as they attach onto the dorsal aspect of the distal phalanx. So just to bear in mind that these are not the only important structures. I think they occupy the majority of our exam, but clearly at all the joints of the fingers you can see collateral ligaments. This is just an example of one at the second metacarpal phalangeal joint. Again, if attention is paid to these areas, you can see them quite well. Also bear in mind we've got paired dorsal and volar interdigital nerves that can be seen reasonably well. Note here that we're at the level of the A5 pulley. Okay, this is distal phalanx, and one of the things you can do is just find the vein, and you know that adjacent to the vein is going to be the fibrovascular plane containing the nerve. Now, obviously, in caliper there, that's more than just nerve tissue, but it's fairly recognizable. Okay, and again, nerves run along with the veins, so relatively easy to find if you look for them. Here, a more proximal image where you can see the paired planes containing digital nerves. And then here's a lateral view at the level, again, we're quite distal here. We're at the level of the distal interphalangeal joint, but you can see some of those fibers of an interdigital nerve. Again, just emphasizing the point that if you take time to look for them, often you can see them. We'll move into relevant pathology at the fingers, and certainly we're going to start with just a brief review of mass lesions, and that has, in large part, due to that seems to be the majority of the indications that I get for imaging of the hand and wrist. And I think that the big picture view is your role to determine is it cystic or solid, which often represents a change in the algorithmic management of that patient. So here is just an example of one such lesion. This is an almost anechoic but circumscribed lesion which demonstrates posterior acoustic through transmission. I don't have color Doppler images for you, but there was no flow. That is compared to this hypoechoic mass lesion immediately adjacent to one of our annular pulleys, which, if anything, demonstrates only slight posterior acoustic enhancement. And that second image also had positive color Doppler flow, so don't forget to put color Doppler on things. Also bear in mind, though, your scale is important. So if you have your flow scale too high, you're going to miss slow flow in lesions. So power Doppler can help in that regard. So certainly the first lesion here was a ganglion cyst near the A2 pulley. The second lesion was a tenosynovial giant cell. Here are two more examples of tenosynovial giant cells. So certainly if you're given a hypoechoic mass lesion that is solid and it's adjacent to a tendon or synovial structure, you're going to guess tenosynovial giant cell, right? It's your most common solid mass lesion in your fingers. But this also emphasizes the relative limitations in ultrasound in characterizing mass lesions further. So this solid hypoechoic mass lesion looks quite similar to this image you saw on the slide previous, representing the tenosynovial giant cell. Again, if you just gave me this image and no history, it's immediately adjacent to a flexor tendon, I would have guessed giant cell. The history from the patient was helpful in this regard, and then he had a flexion contracture of our finger. I'm not telling you that this is in the palmar aspect of his hand, and he had some difficulty extending his finger, so that turned out to be a case of fibromatosis or Dupuytren's contracture. But again, just emphasizing that your ability on imaging alone, once you get to the fact that it's solid, becomes somewhat challenging. To further emphasize that point, I'll show you this solid hypoechoic mass lesion. Here's color Doppler imaging showing the presence of central flow. Compare that to this mass lesion. It looks quite hypoechoic with some posterior acoustic enhancement, but marked central vascular flow. And although it is nonspecific, there is a loose correlation between the degree of abnormal flow in a lesion and its malignant potential. Certainly, I wouldn't guess commonly that lesions in the fingers are malignant. They're rare, but it just so happened that that second case was a leiomyosarcoma. The first case was a schwannoma. So certainly, if you can visualize an interdigital nerve, you want to try to follow that out into this lesion. Occasionally, that can help you make a diagnosis, but otherwise, I just rely on cyst versus solid. Certainly, ultrasound has a role in traumatic imaging. For some reason, this lesion was missed on plain film. I'm not exactly sure why, and the patient presented with a palpable abnormality at the volar aspect of their PIP joint. And on ultrasound, you can see that that represents a focal echogenic deformity of the volar end plate. You can see mild deformity of the flexor tendon as it passes over, and then your volar plate attaches directly onto the lesion. So this is a classic volar end plate avulsion. We did some oblique views and radiography and confirmed it there, not that it needed it. But you can even see things like that. This is an example of an acute trauma of one of the Michigan State University football players, one of the running backs, mid-season. He got his finger held up in a face mask during practice. So this is at the flexor surface of his fourth finger, and you can see there's a small stump of slight asymmetric echogenic tissue where we expect to see FDP tendon, but really proximal to that, there's no identifiable tendon tissue. That kind of heterogeneous phlegmonous-looking tissue just represents hematoma. So the next question we're going to ask is where did the tendon go? I mean, how far is it retracted? Scanning proximally at the level of the PIP joint, you can nicely see the insertional fibers of the FDS paired here, both radial and ulnar aspects of the volar surface. But again, only that kind of phlegmonous hematoma-looking tissue where we expect to see FDP tendon, but no identifiable tendon tissue. At the level of the proximal phalanx, we only see FDS, no FDP. It's not until we get to the level of the metacarpal shaft that's shown in yellow, you see the proximal stump of the flexor digitorum profundus tendon. One of the other things that you want to make sure that you do, which is of great utility to your orthopedist, is attempt to give them landmarks for how far that tendon is retracted. And the technologist here, without any of my doing, identified the MCP joint and gave a measurement for how far proximal to it that tendon was retracted. So certainly if I gave you this history, I think you'd predict the diagnosis before I showed you any images whatsoever. So in an acute injury in a rock climber, you're going to think of an annular pulley lesion. This is not one of my cases, but I think it just demonstrates the relevant points. Here you see the flexor digitorum tendon in this case, and it clearly is distracted from the volar surface of that osseous structure to an asymmetric degree. And then furthermore, shown in white arrows, this came out of an AJR article recently, by the way. But again, you see hematoma, and then the A2 pulley is just substantially thickened and abnormally hypoechoic. You shouldn't see it quite that well, indicating manifestations of injury. And you can also see manifestations of chronic and repetitive trauma in tendons. So this is a mid-aged woman that came in who had some popping and pain at the palmar aspect, I think it's of her fourth finger. And what you can see here is the flexor digitorum profundus tendon but a clearly defined cleft between the two components of the flexor digitorum superficialis, or longitudinal split tear at this level. Slightly more distal image shows the same split. But this became much more interesting when we performed dynamic imaging. So again, easier real time to see this rather than this static image. But take my word for it, there's flexor digitorum profundus tendon. 3 bundles of the FDS were identified. So what was happening when she extended her finger is that 2 of these lateral bundles here were actually snapping around the flexor digitorum profundus tendon, which is information that I would doubt would be able to identify on a static MR examination. Unfortunately, the patient declined surgery, so our hand and wrist surgeon will often operate on findings like this, but she declined it, so we don't have any surgical correlation for that one. So we alluded previously in the talk to trigger finger. This is, again, not an uncommon diagnosis. So here, just recognize that that A1 pulley is too thick, and if you didn't believe it, you certainly have another normal control. So this is the 4th finger. The technologist is a little bit oblique, but demonstrates the normal thickness of an annular pulley, and this one is substantially more thickened, on the order of 2.5 millimeters or so. And not only that, but if you look at the flexor tendons, they're markedly thickened and hypoechoic. In long axis, you can see the substantial thickening of the flexor tendons just proximal to the pulley in this patient with trigger finger. So in conclusion, I hope that we touched on the relevance of the examination and covered normal technique and normal anatomy for you. And again, I hope it was elucidative. Thank you.